Okay. Hi, I'm Alexa Mira, and we're going to start us off. It is 5 o'clock, and with all Omeract traditions, we have some really big controversial questions, and we are excited for all the passion that is in this room to help us answer these big questions. So this topic of this SIG is the ARE working group, and AREs are immune-related adverse events. And for the people, just so you know, I'm Alexa Mira. I am the American or North America contingency. This is David Liu, and he's the Australian. We have Marie Costine, our European. We have our fellow Nalasha Ghosh, and we have our patient partner, Kara Corpse here. So everyone will be speaking in different things. Come in, their seats, grab wherever. And so we'll quickly go through. Okay, what we're going to talk about is quick background. And the only reason why we're going to give some background is this is a new disease. So I need to know why you all should care. And then updates on where we're exactly at. And then the questions that we want you to answer. Okay. This is where we'll get to. All right. So this is us so far. I just kind of introduced us. We have some other patient partners as well. Oliver Terry is our Canadian medical student who this school would not let him off leave to come here to this meeting. So we'll have to try better next time. And Marianne, who's in Europe. And so at the moment, we have 20 represented, and we're hoping that we'll get more in time. And then obviously you all should know about the onion, though it's not quite as onion looking, but where we're kind of getting to. And we're not going to go through everything, but obviously this is what we're trying to gain to. So this is where we're at right now in the generating stage. So we'll go through exactly what we have so you guys just know where we're at. I wanted to quickly, again, overview why we're here. So what is immunotherapy? So to know what is immune-related adverse events. So fundamentally, the new cancer treatments basically disrupt the immune system to turn off very specific regulating checkpoints to allow the immune system to upregulate itself, to allow the body to attack the cancer itself. Really cool, Nobel Prize winning 2018 for both of them. So it's a very different way. And we're going to get to why we're starting with cancer to why we're here for rheumatology, because I hear you on all of that. These are the checkpoints. I know there's a camera, but the PD1 and the PDL1s and the CTLA4, and there's a lot of other ones below that they're getting to. So it's not, there's 3 on the market, well, 4 on the market to be a lot more on the market. So therefore, again, normal immune system, disrupt immune system, upregulate immune system, attack cancer. Why this is important? There are totally different side effects of what traditional chemotherapy is. So when you think of cancer and cancer therapy, we all have a way of thinking about the treatment and how it affects us and how it affects patients. And this is a different ballgame. And so again, this is here for you all just to give you the background and the context, because this is a new disease that we're going to be describing to understand why this is important. So basically, again, immunotherapy attacks the immune system, whereas traditional chemotherapy, right, the tumor or just any over rapid cell, the side effects are very toxic, often cumulative, right? They have neuropathy, the cardiomyopathy over time. Oop, the back one. Whereas immunotherapy is very different. Their side effects, as we're going to talk about, that disrupt the immune system. And when we disrupt the immune system, we're all here for autoimmune diseases. There's resistance. The side effects are often immediate, right? Hair loss, nausea, all of those things. Whereas immunotherapy is a whole different ballgame and how often they get them and when they get them. Okay. This is why this is a big deal. Cancer is entering a paradigm shift, which is really exciting. I want to make this clear. Our whole reason of being here is not to minimize the excitement. We're here to help our fellow oncologists. That is it. That basically there is a change of survival because of these drugs that we've not seen before. And that's huge. So this is really important. All right. And like melanoma, for example, right? When we think of melanoma, it's terrifying. People die. People are dying less and they're living longer. So this is really, really important. In general, survival changed from 42 to 55% for metastatic disease. Big deal. It's a big deal. So why are we here? We're here because when you disrupt the immune system, you open the door to autoimmune disease. And these are the side effects. And these are what's called AREs, or immune-related adverse events. So immunotherapy side effects cause immune-related adverse events. And so this is kind of what we're beginning to kind of talk about. Now, Carrie, you had a really good kind of comment on that earlier as our patient. Do you want to talk about the side effects in cancer just really quickly? Any of it from the patient perspective or immunology's perspective?
Overview. Okay. So I think what you're getting at is that there's an overlay in side effects from different parts of the treatment. And so as a patient, you're thinking about it initially in the, oh, I'm getting chemotherapy and I'm getting all of these things and I expect certain things. But then when they introduce an immunotherapy, I think as a patient, you think about it from the standpoint of they're telling me this not only could extend my life, but save my life, which is a very big deal. And so you're sort of willing as a patient to look at it and say, oh yeah, hit me with this stuff. And then, for example, you get a little bit of a rash and you're like, meh, no big deal. You're going to save my life. Hit me with it again. And you do that over and over and over again. And because of the nature of what these drugs do, and the fact that it can be delayed over the course of your treatment time, I think there's a different way of thinking about the way that this type of disease develops, both from a clinical standpoint and as a patient, because I'm a year and a month out from the last time I got the checkpoint inhibitor that I was treated with, and I'm still developing stuff, which is really interesting and great and fun. And
that's why we're here.
By me.
That's why we're here.
But there's also the consideration of a totally different way of thinking about it, because there are different tolerance levels for each individual, but you've layered on the extend my life, save my life consideration that changes the way you think about not only inducing more disease in the interest of saving a person, but how are you going to treat what you've done in the process of saving their life. And don't get me wrong, I will just put it out to the entire room. I don't regret a thing. Like my whole body's on fire. Don't care. I'm cancer free now. So it did its job. We'll manage the rest of it.
Clap to that. Sorry. That's a really big deal. I just think that really sets the framework of why we're here. And it's not to not take away from the amazingness of what immunotherapy does. It is how then to ensure how to live on fire a little less fiery and a little bit more tolerably, right? That's the idea. So immune-related adverse events can literally affect any organ at any point at any time. So this is a nice just kind of overview. And we're not going to go into all the side effects. There are talks amongst themselves, but just looking, it can be any organ and it can come overnight. Most of the time, these immune-related adverse events are within the first 3 treatments. They get treatments. The immunotherapy is every 3 weeks. It's an IV. So it's usually in the beginning. It doesn't mean it doesn't happen at any point. And it doesn't mean it can't happen after the immunotherapy is already stopped. And the reason for that is these drugs have an interesting persistence. The more immunotherapy you get, the longer it lasts in your system. But we don't know for exactly how long. And so there are patients that are on these drugs to save their life for cancer for years. So then how long is the cumulative effect? So we don't know. So if you stop it after being on it for 5 years, how many more years are you at risk for developing adverse events? We don't know. But these are the interesting questions that we're going to begin to tackle. And then the second question is, just because you have an adverse event, and this is your life-saving treatment, can we give it to you again? And then how do we give it again? And this is a big question that we also know nothing about, that we continue to question about. So these are the big things that we're starting to tackle in this SIG. We don't expect you to answer all of these questions by the end of this hour and a half. Okay. So why are we here? Fundamentally, like she said, what do we do for the treatments, right? We have a lot of questions. We've been told in our ACR and EULAR guidelines that we aren't supposed to use certain drugs when patients have cancer within the first 5 years. Now that immunotherapy showed up, those guidelines are now out of the window all of a sudden, and we're using them anyways. Is that right? Do we know a difference, and how should we do it? And what are the right ones, and which ones cause less harm? And again, now not only do we have to treat a disease that looks very similar to other diseases like rheumatoid arthritis or vasculitis or ILD. But are they the same disease? And what are the right treatments? But we also now have to think about the cancer treatment, and we can't mess with the anti-tumor effect that the immunotherapy did, right? So there's another layer on top of it. And then we have a whole other question. What about patients with pre-existing autoimmune disease? What do we do with that? And what do their immune systems look like, and whatever drugs that they're on? And does that matter? Do they have different outcomes? Does those diseases change? And so these are the questions that those of us that are seeing these patients daily are trying to grapple with and answer. And we have very minimal guidelines that are very strongly evidenced. There's a lot of cancer guidelines, and we can talk about that on a different day. But we in rheumatology have a lot of targeted drugs, and we have a lot of opportunity to think about these diseases differently. And so, again, going back to what we're here for, this is where we're at. And we're going to go through all the ones to get to where we need to do to have an outcomes measures for clinical trials for these diseases. And as you know, our onion, our beloved onion, that's the goal to get to. It probably won't be today. And then I think Marie is up.
Thank you. So I will give you an update on the current progress of the group. So we start with the scoping review, and this was led by Nilasha. Thank you so much for your involvement in this work. We decide to focus, of course, on cancer patients who develop rheumatic side effects, but it's quite broad. So we have to make decision, and we decide to focus on inflammatory arthritis, polymyalgia rheumatica, but we also include in this review arthralgia. We exclude patients with pre-existing autoimmune disease, and we only collect de novo symptoms. The intervention was the use of glucocorticoid or any DMARDs or biologic to manage this side effects, and the control were the standard of care according to international recommendation. We capture all the report outcome because it was exploratory. So outcome specific to the rheumatic side effect or oncological outcome or any other outcome. So the manuscript was accepted last year, and here you can see the flow charts, more than 6,000 reference, and we end up with 69 publications through different database. The search was done through March 21, and we kept study providing both clinical description and outcome domain. After discussion, what Nilasha found is that there were really heterogeneous clinical description of inflammatory arthritis and arthralgia and polymyalgia rheumatica. You can see seven different way of reporting these side effects. So the majority of the paper didn't give a lot of clinical description and talk about arthritis, arthralgia without any details. Other paper, they describe the number of joints involved. Other discuss diagnosis base, so ARA-like or PMR-like or spondyloarthritis, even if we see that it's a different disease. Well, some discuss small joint versus large joint involvement, and few only talk about inflammatory arthritis. So there's really a need for a better definition, and we have this ongoing work with ACR and EULAR classification criteria to have a clear definition of what happened. And regarding the outcome domain, so they were mapped to core area according to the OMRACT 2.1 filter. And also we observe a lot of heterogeneity in reporting this immune-related adverse event. So it's why we are there, because we need really a classification criteria and outcome definition. So you see that the majority of signs map to pathophysiology and signs, symptoms, but also laboratory results, imaging, Of course, impact of health condition and life impact, as Kara said, and the oncological outcome. We will have to deal with this outcome, and this will be a point of the discussion. And the treatment use, so it was related to resource use and societal area. So we identify some domain with this scoping review, and the next step was the qualitative interview to capture and to explore domain from patient perspective. So we prepare and validate our protocol with 3 patients. At this time, Kara was not already in the team. So Iwe from Germany, Marianne from Netherlands, and Oliver from Canada. We had 3 parts in this work. First, really discussing about patient experience, then have their perspective on outcome domain, and then the opinions on what we identify from literature review. We already conduct 10 interviews in France. You see 6 women, 4 men. There's other ongoing in other countries. So we capture a few of them just to give you an overview of what patient said. So when we ask, can you tell me about how you were diagnosed with a rheumatic adverse event related to cancer treatment, we see a lot of pain as a starting point. And suddenly I had swollen joint, or I could not move or walk. So a lot of mobility symptoms. We can see a sleep disorder, and patients, they often say that they were not really aware of such side effect, or they were informed about possible autoimmune as a side effect, but not really prepared for this one. And regarding the experience with the management of this rheumatic adverse event, they talk a lot about the delay to see a rheumatologist, and they really appreciate the prompt delay. And they also highlight to be confident with both oncologists and rheumatologists, because we have to have shared decision. In what way it affects your life? So you can see I could not drive, I could not go out. I was not able to do anything by myself while I was really active before it happened. I had pain, but I tried to keep daily life going a bit, as you said, Kara. Some patients discuss about sexuality, and some of them, you see, psychologically was a difficult time, but since I have heard the diagnosis of cancer, I knew I will have some difficult time. So, and regarding the treatment, how would you know that this was effective? Of course, if pain goes away or will be less intense, the morning stiffness, the mobility, and they were quite impressed by steroid injection or steroid efficacy. And what would you expect from the treatment? So some patients really don't like medication, and there were a bit explaining that they have to take now extra drug to manage side effects of a drug. So it was a difficult situation. For some of them, it's important to continue the cancer treatment because it's effective, and also to restart physical activity. And this is the last slide, what should be used in future studio research. So we had a lot of answers with pain, mobility, also the stopping the glucocorticoid daily, because they were aware that they can also have side effects if they are taken longer. And the possibility of cancer treatment continuation was quite important. And then we asked their opinions on what we identify from the scoping review. Sometimes it was a bit difficult for them to judge if it's important or not, but we try to capture their opinion in such domain. And here is now place for our main question.
Thank you so much, Maria and Alexa, and thank you all for coming. I think actually at this point, we really just want to recognize some of the the guidance we've had. It's been patient and wise guidance that we've received, and I think we wouldn't, Marie and I particularly as newcomers, would have struggled without the guidance we've had. So people here, including Bing, including Ernest, including Lee, including Susan, I think we're really grateful for all that we've received from them. I think we were really lucky to have an experienced fellow in the form of Nalasha. And of course, without Bev, I think we would have really struggled, but we're very grateful for all of their help. But we've got some questions for the group, because I think through this and more broadly, we anticipate some potential complications on the pathway forward. And we were keen to get all of your thoughts as to what this might mean and how we might navigate this. So we'll go into depth with this, but really there are 3 questions that we're hoping to address today. And that's what we're hoping to spend the remainder of the 1 hour and 10 minutes on. 3 questions. Firstly, about whether in this process of creating domains for, creating tools in general for IRAEs, whether we should learn from our classical disease equivalents and how we might use that. I'll explain that in a moment. Secondly, about the impact of therapies and thinking about how much they need to be specific to the IRA context versus how they might be perceived more broadly throughout rheumatic diseases. And then thirdly, about how much cancer outcome detail we should be including in this process, knowing that the cancer really is the main game for these patients, and how we navigate trying to balance up this within the cancer clinical trial space. So firstly, the first question we have for you, and I'll give a little bit of a background to this. Is it worth us considering measurement tools or preferences from other OMRACT groups with analogous classical rheumatic diseases and seeing whether they apply in our IRA population? Or should we try and understand these preferences without any reference to other rheumatic diseases? Well, what is the background to this? Well, firstly, it should be said that IRA is a distinct entity in and of themselves, that they stand distinct to the rheumatic diseases that they might resemble. Having said that, some patients with immune-related adverse events may have immune-related adverse events that do, on some levels, resemble rheumatoid arthritis, polymyalgia rheumatica, and other rheumatic diseases. And we think, and a number of us have been involved in authoring this, which it's still coming to publication, but the idea that we might learn a little bit about classical inflammatory diseases from immune-related adverse events and vice versa. And that the process would start here, that the classical inflammatory diseases, we know a little bit about the existing clinical construct as similar to what we know about, say, rheumatoid arthritis and polymyalgia rheumatica from OMRACT, and that through a process of new technologies and the oncological milieu, we might use those to learn a little bit more about immune-related adverse events. And then similarly, those might give us some insights through what's sometimes termed bedside to bench insights, might give us some ideas about the classical inflammatory diseases themselves. Having said that, they're very clearly distinct entities, and we don't want to belittle immune-related adverse events in themselves if by mapping them to classical inflammatory diseases. So this is the first discussion point, and I'll give some more granular questions. And what I'd like to do, though, before we throw it to the group, is that for every question, I'd really like to call on Cara to give her thoughts and her experience as to what this has meant for her and how her experiences have informed how she thinks about this. So once again, is it worthwhile considering these precedents, especially from other OMRACT groups with analogous classical rheumatic diseases, and trying to see how they apply to our RA population? Or should we try and do it completely independently of that, or somewhere in between? So in generating immune-related adverse event candidate domains, should we take domains from the work that's been done previously with rheumatoid arthritis and polymyalgia rheumatica, and then should we put that to our stakeholders in consultations, or should we really only examine immune-related adverse event specific elements? And then how would we select which elements this would apply to? And I think the background to this also is that both context and contextual factors for these patients vary, as we'll discuss in a moment. In the future, we'd like to really think about, I think this where it might get even more complicated. How would it influence instrument selection knowing that we will be able to draw on a lot of the detailed work that's gone on in rheumatoid arthritis and polymyalgia rheumatica. But similarly, maybe we could take some of those instruments and with the appropriate cognitive debriefing, we may well be able to use them, or should we try, or maybe perhaps even a full reassessment of the psychometric properties. So Cara, I'm just wondering how your experience has informed your thoughts on this.
I feel like I should disclaimer two things to start with before I talk about my perspective. The first is that I did have an autoimmune disease before I was treated with a checkpoint inhibitor. SLE-like, dermatomyositis-like, it never really had a label, but I had something pre-existing, and it started when I was about 19 years old. So that context there. The other thing that I feel like I should confess to the group is that I'm not just a patient. I'm actually a board-certified immunopathologist with a veterinary degree. So my perspective is a little bit different, and you'll get both sides of that as I think about these questions. David asked me some of these things earlier, and I would say, well, as a patient, I think this and this and this, but there's also this methodologist in my soul that's like, nah, but we have to do these other things. So you're going to get pieces of both of those things from me. So when he asked me this question earlier, he was particularly, not so much the way it's presented here, but he was particularly concerned about what a patient feel like if we looked at other OMERAT groups and other pre-existing framework and domains. How would a patient with an IRA feel about that? And would it feel like there wasn't enough focus on the specific disease? And from the way that I think about it as a patient, I think it's two things. The first is that with something like this, I think honesty in, yeah, what you've got kind of looks like these other things, but we don't know if it is or isn't, is really important. To put a point on it, maybe it looks a little like RA in this particular patient, or maybe it looks like something like lupus in this particular patient, but we don't know if they're the same thing. I think that's powerful because it immediately builds a bridge between you and a patient saying, here's a weird thing that happened to me, especially the patients who don't have pre-existing disease. It also sets up a powerful ability to talk about what's happening to that person, because a lot of folks, even who have not had a pre-existing condition, have heard of rheumatoid arthritis or have heard of lupus. And so they have some basic framework to say, oh, I understand what an autoimmune disease is on a basic level. Or even if they don't, you can use those other conditions as an example to help build their knowledge base so they understand what's happening to them. Then I think there's also power as a patient in hearing, we know about all these other diseases. The fact that we don't completely understand what is occurring in you at this point does not mean we do not have experience treating other entities that might be similar to build upon, so that we can approach your disease not only in new and novel ways, but also with the foundation of knowledge that has already been built up by all of the disciplines in rheumatology. I think that's powerful for patients to hear, because when you hear, you have this weird thing. It's weird. I'm really comfortable with that because of my training, because pathologists spend a lot of time going, I don't know, that's cool though. But as a patient, you don't want to hear that's weird unless you're me. And then you're like, whoa, clinical papers. But being able to say, yeah, this is different, but it's also similar. And we have this foundation, I think is really helpful for a patient to have a baseline to work with their doctor to figure out where to go from there. And I think it informs the rest of the questions that are going to be discussed as well.
Sharing that, Cara. And perhaps we'll open it to the floor for all. Yes. Speaking to the microphone.
I know that the typical OMERACT approach is often to start with RA if we have something that we're trying to tackle. That said, I think, at least the limited exposure I have to this and what I know about it, I think if we focus on just RA, we're going to miss a lot. And so I'm already thinking like, okay, maybe there's like we just do the whole review of systems. Anytime a patient comes into us with these weird symptoms and we're trying to sort of start to classify what it's going to, from both the patient and the rheumatologist perspective, I would really appreciate that we look at it more holistically. And I was a little bit disappointed. I know you needed to start somewhere, but the scoping review, so you're just focused on arthritis and PMR. And I'm like, what else did you miss? Right? I mean, in looking at that actually comprises our AEs. And I understand that we may have to individualize, to your point, Sarah, about how we treat these things, but I think we just don't even have a full understanding of that. How do we get that full understanding?
Hold on. Heard them. I was like, if you shoot your hand up or count one, maybe we'll go in that way.
Tatum from University of Pittsburgh. So I guess my comment is to be able to say if what we're observing is analogous or similar to the classical rheumatic disease, we first need a definition for what we're observing. These patients experience increased arthralgia, and without what we call inflammatory arthritis. There's a concept of activated OA, and then there is RA-like, PMR-like. So is it the same disease but different spectrum of the thing? Because again, and I know there are some efforts to develop a classification criteria. And also similarly, so in this study, for example, you're lumping the PMR like with RA-like, then you feel like the experiences of the patients, who have PMR-like disease versus RA-like, are they going to be similar? Are we going to be using the same domain, same instruments later on? You feel like, again, I feel like first we need a definition of disease, of what we're focusing on, and then we need to look at the domain instruments.
Sure. Shall I speak to that, Alex? Or,
Go ahead. White.
maybe I could just, while we're changing,
Yep.
and I mean, perhaps Spring and others might want to kind of chime in on this. So I think there's been some really excellent points there. I think, first of all, I'll say that we've had to all try and actively not let our view slip into boxes as we've seen the evolution of our understanding of rheumatic immune-related adverse events. And I think that's a constant challenge, and we need to try and continue to do that in everything we do. Having said that, we do have the difficulty that we're similarly trying to define and try and figure out outcome measures at the same time. I think as it happens, most of the folks who are involved with this are involved with the classification criteria exercise as well, which we won't talk about today. But we do see the challenges there and how to define a lot of these things. I think for both the classification criteria as well as OMRAC, we were disappointed not to be able to go more broadly, but we knew that we had to try and find some achievable definition, achievable piece to start with, and we felt that those were the most common and ones that we needed to deal with in the first instance. The reason why we've included both inflammatory arthritis and polymyalgia rheumatica is that we do see that certainly, my experience, I think most of the experience of clinicians who take care of rheumatic immune-related events is that we do see this overlap syndrome in between where patients have a polymyalgic feel early on and quickly develop an aggressive inflammatory arthritis following that. So we found it difficult to be able to draw a line there. There was we did think about that a lot. It's been challenging, and hence why we've tried to capture that as a whole. Having said that, for the classification criteria, we've considered using sub-classifications to try and deal with that, knowing that potentially in the future that different therapies may well be appropriate for different sub-classifications. And so I think what I'm trying to say there, it's a delicate balance to try and navigate that, but one we are very conscious of, and we appreciate you bringing it up. Thank you. Thank you.
Hi, Colonel Stevens. So I'm going to make a mess of this. So I think there's a 3x3x2 matrix. First, yes. All right. Yeah. So, all right. First thing in consideration is patient cured, in remission, or still active cancer. Second is what is the immunotherapy that was engaged? Because one of the key aspects to this is what is, and this is the subset, what part of the immune system that was engaged specifically for the treatment of the cancer, and what is the off-target effect, you might say, that's creating the rheumatic disease that we need to treat. Because it's really important to try and piece that out so that those patients who are in remission or still have cancer, we can treat the rheumatic disease without interfering with their oncology treatment, right? And then the third aspect of this is that from the standpoint of treatment, I think in the design of the indications, I think you have new diseases. So basically define the new disease, just like we find Lyme disease years ago, et cetera. Because what you need to know then is, depending on how you define the disease, may actually help you with how to treat the disease without interfering with the oncology treatment. And I think that's key. And whether we start measuring IL-6, TNF, other mediators and such, I think that's important from the standpoint of, one, what is the immune system part that you need to treat the oncology? And then the off-target effects, we have probably drugs to do that. And then that'll help with the classification, but also the testing of drugs. And try one that works. If it doesn't work, try the next one, and what's the sequence for that? So, good luck.
How we can try and
Things going
better
on.
profile some of these things. But we will, I think, thank you for bringing out some of those points. We've got some more, we will go into some more depth on a number of those issues in slides to come. Yeah, thanks.
So I think, the things that strike me about this group and its work is that, as Randall said, we are dealing with trying to develop outcome measures for a disease that we have not yet defined. And for that reason, as you said, it is very good that the classification criteria work is ongoing in parallel with this. But your specific questions here in terms of taking the domain, as you go through your process, I think that you will not find that any of the things that have been discovered before for all of those other diseases are not going to already be present in what you are doing. But by only looking at those, you will miss many of the clinical characteristics and other factors from the patient perspective that are not included in those current foresights. So my opinion on that particular question is that you, in terms of identifying what you should measure, you need to be, you need to deal with this entity, this spectrum of entities to understand what that is. But your second question, I think, is an interesting one, which is about instrument selection, which obviously is going to be later. But that is an area where I think that there is an opportunity to really jumpstart the process by using things that have been developed for other conditions that are similar and finding out if they are applicable to your situation, rather than thinking that you have to go back and recreate the wheel to develop a definition or to develop an instrument for fatigue or an instrument for pain management or an instrument for physical function. Those are probably not going to vary, but those are going to be very contextually dependent upon the other IREs that have taken place, the cancer itself, and the general functional status of the patient from the cancer and from previous chemotherapy. So that opportunity to really get into the contextual factors, especially from the patient perspective, because I found it very interesting, sort of your perspective as a patient. We've done qualitative work at Art Center as well around this, and it is highly variable from patient to patient in terms of the risk benefit and the decision to treat and how aggressive to be versus the cancer, the sort of trade-off between cancer survival versus the severity of the IRAEs. And I think that's also going to be very important to capture, but I don't know how you actually do that as an outcome measure. There's a contextual factors group, but I don't think that they would be able to deal with the complexity of this.
Martin?
So first of all, I think this is one of the most exciting fields in rheumatology today, and I'd like to applaud you for bringing it on and trying to get here and think about outcome measures, like Bing said, where the disease hasn't been properly defined. So I echo that the work of classification and teasing out the relationship with the cancer, all of that is really important. But if you're the outcome group, you have someone else do it. You could be on both groups if you want to stop living outside of the scientific world altogether. So But please don't mix up those two tasks, because outcome, and everybody's talking about RA. RA was our first core step, and we're justifiably really proud of it, but it was the first. It was never developed according to the guidelines we have in place today. So we, as old OMER actors, know we've got to go back to the RA core set and, redo it. And nobody's doing it for a very good reason. So don't get hung up about the RA core set. We have a framework now. And I think the key element here is the middle part, which is life impact. And if you keep on the generic level of life impact, all of a sudden it's really easy, because you don't care what is happening to what part of the body, but you're actually asking the patient, so whatever it is you have, how is that impacting on your life today? And you go to generic instruments, and you can have actually, sufficient feedback from lots of different patients with lots of different AEs. You could get to that fairly easy. And then the pathophysiology is going to be incredibly hard, but you could sort of defer that and say, well, you could just count the number of criteria the patient meets for all these different diseases we have. You just do a numbers counting game and forget about that for a couple of years and focus on life impact. That would be my.
I like that one. Makes it simple. Made it sound so eloquent and simple, which it's not.
Indeed. Thank you very much, because I think that is a really important question that, as you have done in the introduction, will permit us also to understand other mechanisms of our inflammatory diseases. You were telling that the diseases are not the same. They don't behave like the disease they look like. And I think because probably they are not the same disease as you think, they generate the same pain, and you know what it is, the impact on life, because you have asked the patient. But even if you are focusing on the impact, I would say that you will not change this if you do not understand what it is happening. So I respectfully disagree with what you were telling, because I think that in that case, you have, no. I think that you were telling PMR like rheumatoid arthritis like arthralgia, because they sometimes do not respond to the same therapies that you cannot do sometimes, because there is no inflammation. When you use imaging, not all of them have inflammation. They have pain in these joints. You try to treat them as rheumatoid arthritis or polymyalgia. They do not respond because it's not the same disease. It's just the pain localized. So I think that you have also to use imaging to try to characterize, and then you have pain, and then probably you can treat, and then you have the improvement in the impact in the quality of life. But if you have just the symptoms and you cannot treat, you start to treat thinking that it is an inflammatory disease, then probably is not the good thing. So go to both.
All right, so Merkel, the next question. Does that sound? Oh.
I can defer. First of all, I think I wasn't sure until you started the discussion. So now I would agree that starting from scratch from the beginning is, I think, the right way to do it. And it is a new disease. I think it's exciting and intriguing, but it's also really hard. I also think this disease or disease spectrum is changing and will change. And that's a little bit of a problem. So we have many new drugs coming out, and there are different practices in oncology changing their practice, the dosing, they're changing what they're doing before they even call us. So I think it's a moving target, and that is an issue. I also think that you could do it perfectly by the wonderful many thousand-step OMERAC workbook, and you may never get it done.
or you could be more practical. And so how do you weigh that and get something done that's actually useful? A couple other points to consider is, are you looking for outcomes that are useful in trials that will inform clinicians and patients, which is important? Or are you looking for outcomes that will lead to drug approval for the use of those drugs? Those are different things, and we don't think about the latter anywhere near enough in OMRAC, in my opinion. And so it's something to consider. Third thing is, I would respectfully disagree to some extent with Dr. Borg, A, because it's fun, and B, because it generates discussion. I think that you could just do a patient global or a physician global or both if you wanted to sort of composite all, although those tend not to work in that regard. I think that you should consider, you're doing domains, not instruments. So you're asking what to measure, not how to measure it. But it's impossible to not think about how to measure it along the way. And I would let the work, the long-standing and lots of work done in rheumatoid arthritis and now polymyalgia rheumatica inform how you craft what you're doing to some extent. The phraseology, the terminology, because to the extent that it's acceptably parallel, it will be beneficial to you as you move forward and as you consider instruments, et cetera, because I think you're going to have to borrow and such. But I think that, yes, pain is important, function is important, but those of us who see these patients, incredibly complicated discussion. Where are they in the course of their chemotherapy? I saw a patient this week who got recurrent giant cell arteritis polymyalgia rheumatica, but his lung cancer is now more widely metastatic. It's a very different discussion than when I had with him when he first was treated. And so I think it's hard, and I think I'd give yourself some outs by, I like the matrix idea because I think you're going to need different things at different stages. But if you make it so complicated, you'll never get it done.
And then we'll move on to the next question after.
So I think we are back to old OMRAC and we can't get a word in. So I want to flag up two C words that are really important for you to consider, because your question talk about candidate domains. You're not talking about domains. You're talking about identify potential candidate domains. So I don't know that you need to be so restrictive. But if you want to go back to conventional psychometric, the most important word when you're doing the patient-focused group work is comprehensiveness. You don't want to miss important domains just because you borrow it from other diseases. You should come up with a list to make sure the list are comprehensive, and then you can decide with further work whether some of the domains are relevant. You don't need to decide now. You need to do further work to validate the domains are relevant, but you definitely want to be comprehensive. But I think one thing Peter mentioned is very important, is that you don't want to lose all your memories about what has been done before. And it's not restricted just to rheumatoid arthritis, but all inflammatory arthritis. You have a memory of how the domains will work. Now, one of the key questions that has been flagged is, now, if a common symptom is arthralgia, in the context of domain, you need to think, is arthralgia in the domain of pain, or is in the domain of a tender joint? This is for you to reflect upon. Is the naming of the domain is it going to be consistent with what we have done before? Would that be helpful or not helpful?
Thank you so much. All that was a really enlightening discussion and plenty for us to go away and think about. So the second thing, and there's a little bit of background here, and actually a lot of the points which were alluded to in amongst that, we will show some content slides to give the appropriate background. But to what extent should the impact of therapies such as glucocorticoids, steroids, specific to the immune-related adverse event setting be captured, specific to the immune-related adverse setting? So some background. So glucocorticoids are used extensively in oncology, in immuno-oncology, and there's an increasing appreciation that they're similarly imperfect in some ways. And So this is data from subspecialty oncology subspecialty oncology journal, which doesn't really usually always look more broadly at the kind of things that we do. And you can see that that kind of thing on that right-hand side is captured, that a number of different elements are very familiar. Of course, the other side of it is that steroids aren't enough a lot of the time, and that's what we see on the left-hand side. So we do have this, there's a debate within immuno-oncology and within certainly how we deal with rheumatic immune-related adverse events as to what impact glucocorticoids in particular they will have on the anti-tumor inflammatory response. Because that's really what we're trying to achieve here, that anti-tumor inflammatory response. I think early on we were informed a little bit by this seminal paper from 2015, which really looked at patients who had steroids versus those who didn't, and looked at the Kaplan-Meier survival curves, and really across the board saw very similar types of outcomes, possibly even slightly favorable to steroids in some circumstances. But really that comes down to a balance, because we have seen that immune-related adverse events seem to confer a favorable oncological response. So those patients who are receiving steroids for immune-related adverse events, they will already have that favorable oncological response, and then subsequently have the impact of glucocorticoids. So part of that is also the fact that glucocorticoids are used for multiple indications within cancer. So not just immune-related adverse events, but also they're sometimes used for nausea. They're sometimes used for tumor-related edema, and for fatigue, and many other different situations. It's been subsequently thought that maybe 10 milligrams will be a tipping point. We won't show those data today, but it's still uncertain and somewhat controversial. There's been some discussion that it will be, if you stratify what those steroids are used for on the basis of their indication, that we may be able to get a better insight. And so this is later data, which breaks it down on the basis of patients who didn't receive steroids, and then who had steroids at baseline for supportive reasons, not cancer-related, steroids for palliative reasons for cancer symptom management, and then steroids for immune-related adverse events. And the steroids for immune-related adverse events is the orange line, and the steroid naive one is the blue line, and those may well track a little bit higher there. But I think there's still some uncertainty. Sorry, yes, thank you so much. Yeah. So maybe that channeling is contributing to some of this. I think what we also may see as well is that the timing of the steroids is important. And I think one thing that's relevant throughout all of this, and has already been alluded to, is really about the stage of cancer therapy. The IRE therapy occurs, knowing that different stages there are different immunological processes going on, and there are also different impacts. And we've already heard about this, and I'm sure Kara will talk a bit about this. But there's been some suggestion, for example, that glucocorticoids in the first 30 days may will be confer worse outcomes compared to not having glucocorticoids in the first 30 days. And that's what we're seeing in Kaplan-Meier in the top left-hand corner, that the red is a line which drops down the steroids in the first 30 days. And then, yeah, thank you, Alexa. Would you mind moving your arm now so I can show that? And as you can see, the numbers are there as well, and the indication, there are multiple different indications which those used for. The data on the right is from France, Marie and others, Alice Tisson, who's also involved with our group, looking at patients with pre-existing autoimmune disease and whether they had immunosuppression at the beginning or not. And you can see that there was also some difference in amongst that as well. But I think this data is probably even more pertinent. This breaks down looking at indication as well as timing. So in this case, the tipping point is 2 months or more in blue, and then less than 2 months in the red, and looking at patients who are receiving steroids for immune-related adverse events, and then for non-immune-related adverse event indications. And you can see that the graphs look similar irrespective of whether it's immune-related adverse events or not that we're treating. So that raises all sorts of questions, but certainly some concern when we clinically, when we're in the clinic, saying that we can't say that steroids are without an impact on cancer progression in these patients. We also have started to realize that perhaps this might not just apply to glucocorticoids. And so this is a paper that just was published in the Annals of Rheumatic Diseases, led by Anne Bass and Laura Capelli, who works with Bing. Bing and many others were on here, the 6 US sites, looking at therapy, at TNF inhibitors, IL-6 receptor inhibitors, and methotrexate, and comparing survival in amongst that, adjusting for many things. What I'll say here is that there may well be differential impacts on cancer progression, methotrexate versus perhaps TNF inhibitors and IL-6 receptor inhibitors, knowing that this is retrospective data. So this is observational data, and really that a randomized control trial is the only way to really know. And so this is also the work that being mentioned that was led by Laura Capelli at Hopkins, looking at the complex decision-making that our patients are faced with. Really that they have to balance in the blue, the cancer diagnosis and their management, with their dealings with their oncologist, versus in the red, the immune checkpoint inhibitor-induced inflammatory arthritis in this case. Does that mean, what does that mean for immunotherapy continuing, stopping? What does that mean for decisions about the arthritis, especially knowing what we've discussed just then, the multi-dimensional life impact, and then how all of this goes in terms of the fear of the cancer returning, but also and the decisions to continue immune checkpoint inhibitors versus all the gaps that exist for our patients with inflammatory arthritis and other immune-related adverse events. So really the questions that we're trying to ask here are, to what extent should the impact of therapies that we might use for immune-related adverse events be looking specifically at patients in the immune-related adverse event setting, knowing as well that they do seem to have all the same problems, perhaps thanks to survivorship, that patients, other rheumatic disease patients might have from glucocorticoids, for example. So might immune-related adverse event therapy-related cancer progression be reflected as a specified adverse event, even though the causality is hard to determine? And we know that patients can progress, their cancer can progress irrespective of immune-related adverse event therapy, irrespective of immune-related adverse events. So that's hard to determine in terms of causality. To what extent can it be presumed that glucocorticosteroids might have a similar benefit adverse event profile compared to other rheumatic diseases? How do we delineate the domains that are heavily impacted by both disease, therapy, and other factors? So for example, fatigue might occur from the immune-related adverse event itself, from the immune-related adverse event therapies, then also from the underlying cancer, apart from any other reasons that might occur. And then in the future, for instrument selection, how do we make sure that the tools we use the instruments we use are appropriately responsive in terms of cancer progression? So maybe I'll just pass to Cara to give her comments on this before we go to the floor.
So for my answer to the first question, I took off my scientist hat and gave you patient perspective only. It is literally impossible for me to do that with this one. I've tried. It doesn't work because the only piece of my brain that went primal during the entire phase of my treatment was, I know what steroids and all these other therapies are going to do to my immune system. Don't you dare put those in me unless we absolutely have to. I want my cancer to melt. So I think this is going to be extraordinarily patient dependent. I think it's going to vary, maybe some, maybe not some, between patients who have pre-existing disease and those who don't have pre-existing disease and are experiencing an autoimmune event for the first time in their life. Because when I first, so mine started with a rash. And I was like, doesn't even itch. Don't you dare treat this. Let's just watch it. It'll go away. I got Pembro. It developed a week after a dose. So I got Pembro again 2 weeks later. And I was like, it's fine, it's fine. Nothing happened. I got to my third dose of Pembro. And my right knee swelled up and was so inflamed it was bright red. And by 3 o'clock in the morning, I was dangerously tachycardic and had 104-degree fever. Went to the ER. They controlled the fever, pumped me full of fluids, and were giving me a lot of antibiotics because they were afraid I was septic. But I was like, please don't give me steroids. They didn't because they were afraid I was septic. But I continued down that path. And my oncologist is a trooper because she was dealing with somebody who understood the way the immune system worked. I didn't let her give me steroids until I got myocarditis and nearly killed me. Yeah, well, that too. I made them do the MRI and I pulled up the MRI and was like, oh yeah, that's on fire. Okay, lowish dose steroids. That'll be fine. I realize I'm not a completely standard patient and some patients would react differently. Again, I think it's going to be individual personal thresholds for this, but I think a lot of patients are going to be very worried about this. They're going to be worried about, can we get rid of the cancer in the first place? I want you to extend or save my life. I don't want you to do something that's going to stop what most people see as a miracle drug from doing what it is supposed to do. I just had extra complicated layers because I knew what was going to happen. And I was already freaked out because I had triple negative breast cancer. And so I was already getting pumped full of steroids because they have to give you steroids to give you the chemo that treats it. Because paclitaxel is one of the drugs that I was treated with, and I was getting high dose steroids for that to begin with. So I was already like, my Pembro, don't stop it. So I think this is one of these questions where you're like, well, we have to treat this thing. And it may or may not, and we have some data, but we need more data impact cancer treatment. I think patients are going to be very worried about this because even my highly educated, I understand all of this brain, again, went primal and was like, don't you dare. Don't you dare stop my cancer treatment. I don't want a delay or an impediment to that. So from a patient perspective, I think this is one of the most important questions to include in this whole discussion.
I'll start and just say, I mean, and I'm going to go back to Lisa. I don't know if Lisa's still in the room, but he did say this is for clinical trials, right? So, I mean, presumably you're creating this domain set to eventually inform how we look at clinical trials and the outcomes we will eventually measure. As Peter said, we don't really think about the domain, develop thinking about the outcomes. Even though we know we're not supposed to measure the outcomes yet when we're thinking about the domain. So I don't know, maybe I'm just looking at this too simplistically. Why wouldn't you be capturing this, but it's in the basis of a clinical trial? I mean, if it's maybe a background therapy.
Yes. And some of it is some of the cancer guidelines. We're here first on these two. Have it without us, right? Cancer guidelines do different things for various different reasons. So it's hard. That's why. So good.
No, I think this is a problem not only for this specific disease, but also for other rheumatic diseases, right? Lupus, RA. So patients will usually, a lot of patients have concomitant fibromyalgia. And it is hard to differentiate. Is it from the fatigue is from the fibromyalgia versus RA? In similar situation here, is it fatigue from cancer or is it really from the immune-related adverse event itself? So it's an inherent problem. I think it is going to be very difficult to differentiate. And if this symptom, the domain, fatigue domain, is what matters most to the patients, then that has to be a principal outcome measure of interest ultimately. So that would be.
No, I'm just thinking attribution is so difficult. And I mean, it's usually impossible. And in this context, you have sort of a positive and a negative attribution that would need to be assessed in some way. So even if we're not talking about instruments, the whole domain becomes incredibly difficult if you start attributing things. So if glucocorticoids or TNF inhibitors or whatever treatment you are giving is impacting the patient, and you showed an impact on real survival, yes, you have to measure survival. And if you're going to do a trial on treating certain immune-related adverse events with anti-TNF or with glucocorticoids or whatever, yes, you'll measure survival and you'll measure all kinds of things, fatigue, whatever is important to that point. And at the end of the trial, you'll know whether the survival was better or worse in the patient treated with whatever you were testing. So I really think you shouldn't be mixing it up because it's going to be really, really impossible to progress.
So, couple of questions. When you're looking at those steroids, were they chronic or were they acute?
And really, I think that's, yeah, I mean, some of the ones used after that window have, I mean, obviously have been acute then. There's still, I think, a lot of controversy, and I think it's still not entirely certain, if we're to be honest.
Because that needs to be captured when you look at this from the standpoint of a, ID of 100, 200 medrol can be different than 3 months or 6 months of lower dose corticosteroid. So I think those have to be taken into account from the standpoint of survival and effect and benefit.
No, I could give you the answer for a study that I've monitored with 1,000 patients who have been treated with checkpoint inhibitors. It's very difficult with steroids because many of the patients in the longitudinal study are just they're on dexamethasone because they have cerebral metastasis, which increase the intracranial pressure. So it's
Yeah, so this is, hold on. All right, we got 2 and then 3 and then 4.
so I'm coming in from FDA and drug company perspective. I'm wondering the second question, we might actually cross over to drug interactions area. Okay, I would think that maybe we should answer the first question first. Because like say, I mean, we have a lot of comment that it is almost not, you're not able to execute. But, but FDA or drug company, when they do this, they will have to submit drug interactions, things like that, not just, immunotherapies, but every other therapy. You have to make sure that a certain class of drugs, there's no, you need to show that information. So this actually is probably in that area, probably not the most important thing for Omorac to address at this time.
Control for how much steroids they get. The trials.
I just have some thoughts. I agree that steroids is something that is very difficult to evaluate. Also, when you see that if you give steroids in the first 2 months, they die first. If you delay the steroids, they die later. First, because you do not know how they started from. Probably they were more severe and they needed steroids before, or they had other reason for any steroids, and so it is not completely the influence of steroids that made these worse outcomes. So I am sure that what you were also telling, if you gave steroids since the beginning, it means that they need also this. So I think that looking at this, it is quite difficult. About the measurement, I would not mix, I would say, domains that can be also impacted by the cancer. So I will not measure fatigue. I will just try to focus on what I feel it is really the adverse event. So, for example, the improvement of the swollen joints or something else, because what it is also impacted by the therapies of the cancer or the cancer itself cannot be measured. So I think that it will be a failing that trial. This is my point.
All right, come on.
I'm going to make one point. I'm going to respond to that because I think it's intriguing. I'm not sure how, I think it's impossible to separate out what is also from the cancer, but you have to take what the patient is saying is happening. I mean, cancer can cause pain and fatigue. It can cause bone pain. It can cause pain near joints that looks like, sounds like joint pain. It can cause HPOA. It can cause lots of things that, and that's why defining disease is important. Depends on the time of the trial. Is the cancer stable? You have to figure that out. But again, you could come up with lots of reasons not to do it, but the patient still is uncomfortable or worse. And so we want to help them. So I'm not sure I agree with that. I also, I'm not sure why you're thinking about treatment. I would posit that our domains and our outcomes could be and should be treatment agnostic. Glucocorticoids were used for 100 years, well, not quite, but, and we may still be using them, but we may not. In some diseases, we're not using them. What does it matter? It's whatever the treatment is, we can hopefully use different treatments and other modalities. It could be behavioral changes, could be lots of things. I think mixing in the treatments, I think there are adverse events of glucocorticoids, and they're good events. We have measures that we're doing that. But I wonder how many people in the room would, I'm not sure that, I think this, which is, I think it should be agnostic to the treatment. Domains are domains, and outcomes are outcomes.
Measure the use of our drug in this autoimmune disease. And I think that if we use the standard measure that they are fatigue, we are not measuring the impact of therapies of cancer on some domains.
I want to weigh on this fatigue, pain, function issue. And really say that we have to measure those things. The patients tell us that these domains are the important domains in terms of their lives. And from taking care of a lot of these patients and from doing the qualitative work and seeing qualitative work from others, those are constants. So we have to think about those things as things to be measured. Attribution is not a factor. When PROMIS was created as a measurement system, like it or not, it was created with the idea that fatigue, pain interference, physical function, they were universal concepts that could be attributed from multiple different things. But the measurement system allows you to collect that information, and then you can determine, as a result of therapy, is there change in those domains, right? But the domain is still the important thing to measure. But, you know, and you can measure these constructs without attribution. So I would, that's my way on modesty.
So I think there's a combination of things here to address that, because on the one hand, you want to try to parse it out, but I think this is an opportunity to talk to the oncologist, because they're asking about fatigue, they're asking about pain, they're asking about swelling, they're asking about yada yada. They're taking numeric measures in surveys every time you go in for a dose of treatment, not just the immunotherapy, but the chemo. Every time I went in, a 3-page form I filled out where I was circling numbers on scales. They have that data. And then you can ask the patient, did it change? We know when it changed. I knew when it changed. I was like, ooh, yep, nope, that's not the way it was supposed to be. Did I call my oncologist first? Yeah, absolutely, because she was my primary point of contact for medical care at that point. But then she was like, oh, yeah, that's not typical. That's not typical. And so then we started watching me more closely because it was weird. That's the benefit of this being weird, is that the oncologists know, especially the ones, and I was lucky, mine is an immunotherapy expert, but the ones who are working with this more and more now, which is most of them, they're going to know what's typical for the drugs they've been using for however long and what is not typical and might be related to immunotherapy. So I think you can talk to your oncologist colleagues and then ask the patient what changed and how it differed from whatever, because I can tell you, not oddly enough, the fatigue from the chemo was drastically different than the character of the fatigue that I got with the immunotherapy adverse events. And both of those were different than the fatigue that I've had since I was 20 years old. Ask the patient, you can measure them all. And I think you're actually going to have.
for patients they're going to take in. That's like SF36, SF52, SF85. Other comments before we move on. Wait, the next question.
Lots for us to think. Yeah. Oh, yeah. So the last. Sorry, is it with so we'll move on. It's related to this, but still a separate question. So, to what detail of cancer outcomes? So to what detail of cancer outcomes should we consider an immune-related adverse outcome measurement, knowing that patients have very diverse cancer journeys? And I think we know that we are playing in the immuno-oncology space within cancer trial space. We'll run our own trials, but they'll be in coordination with oncologists. Oh, sorry, yes, okay. Oh yeah, sorry, the reason why I had that there was just to remind us, of course, that oncologists and rheumatologists have to work very closely together, and amongst this, cancer is really at the forefront of many patients' minds, and certainly is a factor that is important to nearly all patients. We, of course, are in a situation now, which has also been alluded to, that the field of immuno-oncology, specifically with checkpoint inhibitors, has really evolved over time. So I realize this is very small, but to try and fit it all on this page, the columns are different tumor streams, and then you can see the timeline of different FDA approvals in this case. And you can see that early on, really, we were just looking at a few different cancer tumor streams. But now we've got a diversity, and this doesn't even capture everything that occurs in the clinical trial space.
And I think it's important, actually, there's blanket FDA approvals for these drugs that if the cancer, doesn't matter what the primary cancer is, if it has a checkpoint inhibitor signal, PD-1 signal, they can get the drug. I mean, it is changing, and how we think about cancer as well in treatment. So it doesn't have to be lung or colon or breast.
So I think this gets even more complicated because we're looking at, while initially this was used for metastatic disease, really as a kind of Hail Mary last line type of therapy, now we are in a very different situation where different treatment intents and stages are being considered. So not just palliative or curative, but and it's now not just primary systemic therapy, but also adjuvant therapy very commonly. Also in different combinations. So whether it's a single agent versus a combination, most common combination would be a PD-1 or PD-L1 inhibitor with a CTLA-4 inhibitor, but we have now other checkpoints that we're targeting, which we use in combination in various different combinations. In addition to that, just to complicate things, many of these are used in regimens with chemotherapy and, depending on the individual patient situation, radiotherapy as well. Why is all of this important? Why is this relevant? Well, we wonder to what extent should we try and capture those cancer outcomes, knowing those diverse journeys. So if we think that we should be capturing cancer outcomes, should cancer progression also represent an expansion on the core area of death and lifespan, given that it's such an important outcome for immune-related adverse event patients independent of IRA treatment? Also, if we do decide we need to capture cancer outcomes, how do we account for the diverse population with multiple different contextual factors? Should this be incorporated, and knowing as well some patients will have adjuvant therapy, should this be incorporated for all patients, including those with adjuvant therapy, or should there be some stratification? Should it be only mandatory in certain circumstances? And then in the future, we'll have to consider, should instruments be borrowed from the oncological context, and which instruments, how do we decide where to draw the line with those instruments, and to what extent do these need to be retested in the immune-related adverse event, or the rheumatic immune-related adverse event population? So, Cara, I'm wondering whether you've got some thoughts on that.
You go first on this one.
I think I've answered, well, again, let's take the scientist hat off. So I think from a patient perspective, there are two aspects of this. The first is that cancer is a big bad word and it's scary. And so I think when you start to talk to patients about treatments with this and how to look at trials and how to deal with the potential that they're going to develop this disease or they're developing this disease spectrum during treatment. I think the way that a patient talks about and thinks about and decision makes based on is going to be different based on not so much exactly which cancer they have, as was stated, but where they are in the cancer journey. Several people have hit upon this. Are they in treatment? Are they post-treatment? Are they cancer-free? Are they in remission? Where are they in that? And that's going to affect how they look at this. And then I have actually personally seen a difference in the way that I think about these things. And to Alexa's great delight, have been much more willing post-treatment, because now I'm like, okay, I'm in a spot where the immunotherapy has, at least at this point, and fingers crossed for the future, done what it needs to do. And I've achieved an outcome on the cancer side of things that is acceptable and good. Now I need to deal with the rest of this stuff because we've extended / saved my life. So now I'm thinking about these things differently in the context of what do we do about my IRA? So I think if you ask patients about this, they're going to say, yeah, you need to think about what we're doing with my cancer, because cancer is going to kill me long before the IRA potentially is, assuming that it is following some of these more general trends and they don't wait to get treated until it hurts. But I think in a patient's mind, cancer is the thing they're most worried about first. So your measures, if you ran down a list of these different questions and outcomes with a patient, their answer might change post-treatment. And I think you have to think about that. And so I think at least capturing some of these, where are they in their cancer, and what is the long-term outcome of that, so that you're taking into context, this person still has a 5-year survival rate. I think that will make a big difference in the way this data is parsed, because I think, again, you can bucket patients, but you can't bucket all patients, because I think it's going to be drastically different based on those facts.
Thanks. I think that obviously it's mandatory to collect cancer outcome details for these clinical trials. But what is the main objective here? Is it to create like a composite outcome that would take together the IRA outcome, which is the positive effect of the drug we'll be testing, and cancer outcome, and we are frightened of having side effects of the drug. And I think that composite outcomes mixing improvement and side effects can be really difficult to design and then to analyze. So obviously it's important, but is your plan to create this very complicated composite outcome measure that would take both sides of the coins, or should they be collected?
Well, I mean, I think that's why we're coming to this group for a guidance. I mean, I think we're still obviously well and truly looking at domains, but I think that these are the questions that we're trying to determine, and knowing how important it is, but at the same time knowing the complexity we'd run into. What may I ask you? What you?
And also their position there in the onion. I mean, should they be at the same position or different according to the importance of each of them?
Can I ask you what you think about what we should do?
I'm just thinking that if you mix in the same composite outcome measure positive and negative, you will never be able to analyze the global effect. Because if you have 0, so it's been question for other contexts, trying to include side effects of the drug we are testing in terms of hospitalization, for instance, and including positive outcomes. So what we expect of the drug, and actually when you see the numbers, you can't interpret it because you have no idea whether it should be for. Do not mix up measuring disease or measuring response. I think we're talking a little bit more about measuring response. That's a different thing. You want the measures to be able to get you to response, but response criteria, which we'll be talking about at the vasculitis SIG, which I'm sure you'll all go to tomorrow, is a different thing. But
Hold on. There's Ernest, we have Zhang, and then we have these two gentlemen, okay?
So there are systematic review in the constant literature, which categorically show that the type of immune adverse event you see with the different checkpoint inhibitor class are different. And also the range of immune adverse event you get with different cancer type are also different. So I think those are pretty established facts already. So there's no question. Those are potential contextual factors that you need to consider. If you're going to have a cancer outcome, because obviously different cancers have different outcome expectations. But I don't know whether you want to do it at the outcome measure methodology, because there are methods of doing very fine patient stratification with multiple factors called minimalization. So you can do it that way, rather than try to adjust your outcome measure for all these potential contextual factors. Probably easier to do it by minimalization. Then you can have all the predefined categories and you fit the patient to those randomization tables.
One of the things I think that is useful from this activity is one of the things I think that's useful from this activity and the process that's going on is while we think about OMERAC's primary thing traditionally as clinical trials, we have the opportunity with this exercise to also think about what we need to do in longitudinal observational studies to answer the questions that are being raised today. And I think that while things may not be used for trials ultimately, and the ways that things are captured in trials and are somewhat different, the issue of observational studies is extremely important. And I think as we have a registry now of 10 sites, a lot of people in here are in that. Lee, you have registries and work that you're doing in Europe. I don't know if there are registries that are happening in Australia. There's a registry happening in Canada. One of the things that we desperately need is some answer on how do we measure these things and what are the important things to measure regarding steroid use, regarding cancer type, regarding time of treatment, all of those types of things. You know, the community, the larger community of us that are wrestling with this observational study piece of this need to get to those answers quickly. So that we can actually address these things when it comes time for you to design your clinical trial, which is going to be several years down the line. But if the group can get some information that can inform those of us who are working on registries so that we can harmonize our efforts to answer these questions, that would be a tremendous thing beyond the clinical trial that would be extremely important for the world.
Okay, mine will be very brief because I just want to continue on the thing that Phoebe want to make. So I think that what is important here is to focus in order to make sense of your work, and you have to focus on the outcome measures for the immune-related disease. However, these of course are in many ways affected by the cancer outcome. So it is impossible to not take this into consideration. However, I would suggest that you see this as a factor in your equation to adjust for. So, very good.
So my comment would be, we're talking about domains. If you want to talk about composite outcomes, go to the other activity of OMRAC and be educated about how incredibly complex that is. Within a domain, within a specific thing that you're measuring in the domain, for instance, fatigue or pain, yes, you certainly can measure negative and positive things. So if you have a treatment for fatigue, so your fatigue goes down, but there's something else that's putting your fatigue back up, the net result may be no change in fatigue, and you've got to understand what happened. But if you're measuring fatigue, those influences may interact and push the needle down or up. There's nothing you can do about that.
And just to that point, it may be easier to not only know what the cancer is because you know the side effects of that cancer, but also just collecting the treatments that have been given will probably help inform you of what may be the IRA and what may not be the IRA, such as if you're using vaccines or platinum and so forth, you know you're going to get distal neuropathies and so forth, which can be part of an autoimmune disease, but it's typically from a standpoint of a oxaliplatin taxane, there are nuances with that because there's cold allodynia, which is very common with both of them, which is typically not seen in other types of autoimmune diseases. So knowing the therapies involved in cancer is sufficient for what you need. Yeah, I don't think you have to get into the minutia of the cancer itself, but therapies and their adverse events.
One more, and then we will wrap up. Very quickly, I think when you design the clinical trials for this condition, so what you will probably focus on is going to be the efficacy of the therapeutic agent on the ILA, right? And the cancer outcome that you're mentioning here is more of a safety. I would think about the safety outcome rather than efficacy. And I would keep that, again, it's something that you need to measure consistently because it's very important, similar to the other clinical trials. So rather than combining safety and efficacy outcomes into a composite measure, which is very, very difficult to do, I would keep them separate.
Thank you, guys. All right, I think we're done. This was a lot. We've obviously solved the world. You gave us so much to think about. If you guys want to join our group, you guys are welcome to now that we have your name. So awesome. Would love your advice and participation in all of these things. So thank you again. And